Welcome to TouchPoint3. We'll get the class started. Can you hear me?
Yes.
Are y'all ready for me to start?
Yes, go ahead, Janice.
Okay. Good evening, everyone. My topic is Get with the Guidelines, Heart Failure to Reduce Hospital Readmissions in a Community Hospital Setting. My aim is to effectively reduce 30-day hospital readmission rates in a community hospital setting to 16% by June 2019, utilizing Get with the Guidelines heart failure measures. Heart failure affects nearly 6 million Americans. Half of the people who develop heart failure die within 5 years of their diagnoses. Heart failure costs the nation an estimate of $30.7 billion each year. It will increase to $1.1 trillion by 2035. Heart failure accounts for about 8.5% of all disease deaths in the United States. Reason for the effort: because we are delivering ineffective care at my organization. With our team survey, we found that 42% of the team members felt there was poor communication. Team members were not held accountable. Supervisors were not resolving conflict. The patient survey, the patients did not feel enough information was being given to them to make healthy choices. They were not informed about heart failure risk factors. Our heart failure management tool with the chart surveys, showed 25% readmission rates within 30 days of discharge. 40% of the patients got no ICD counseling. 100% of the patients did not receive 1 hour of education. With the discharge audit, we found that 25% of the patients did not get appropriate follow-up with their primary care physicians or specialists. 100% of the patients did not get referred to cardiac rehabilitation at discharge. Expected outcomes: project will lead to the development of an outpatient heart failure clinic, standardization of heart failure education, and improved timely follow-up. This is my team tool and operational definitions. For the teamwork ramp, weekly QI meetings, there will be a minute template and a GRPI meeting survey tool. The outcome measure will be mean percent meeting effectiveness from the tool. The patient part will be a heart failure path mobile app with the survey tool. The outcome will be mean percent interest score in heart failure app. The patient management will be a patient management tool. The outcome will be mean percent of patients managed properly. For the D ramp, it'll be a heart failure discharge algorithm checklist. The mean percent of appropriate discharge of patients with the diagnosis of heart failure. The operational definition will be mean score of interest in heart failure app plus the heart failure management and appropriate discharge. The balancing measure will be for decrease in readmissions to the hospital. The length of stay will not increase. These are my key stakeholders. My cardiologist serves as my mentor. One of the vice presidents over the medical group serves as my sponsor. The initial change core interventions will be A, quality improvement meetings, B, heart failure path app for self-management, C, heart failure management tool, D, heart failure discharge algorithm checklist. Barriers: the team, there may be saturated roles, unengaged team, lack of time, lack of work-life balance, fear of speaking out. For the patients, lack of interest in self-care management, not able to perform care due to illness and or cognitive issues. The heart failure management tool is a comprehensive 3-page tool, and who will be responsible for completing the tool: potential difficulty getting healthcare team members on board to participate in the study. And the discharge algorithm checklist is also a very comprehensive 4-page tool, and who will complete: possibility of unwilling to add another responsibility and lack of interest in the project. These are my references. Thank you.
Well done, Janice.
Okay. Now I need to get back to you all.
All right. Anybody else want to go
Wanna
next? I can go. Are you guys ready? I'm going to screen share. You're going to be blown away. Okay, I have no idea what just happened. Okay, guys. Oh, I have no idea what's happening.
Sarah, do you want me to go ahead and go real quick?
Sure, it appears I'm like not tech savvy by any means.
Okay.
Okay. I'm not screen sharing anymore, right?
Hopefully you guys can see my screen. Is that correct?
Yes.
Okay, I'm going to go ahead then. My name is Amanda Strickland with Frontier Nursing University. My project title is Improving Patient Safety with Respiratory Monitoring using the Michigan Opioid Safety Score during inpatient hospitalization. I will be completing my project at Novant Health Rowan Medical Center. My aim statement is increasing identification and monitoring of high-risk hospitalized patients for post-IV opioid respiratory depression to 70% by April of 2019. The Center for Medicare and Medicaid Services requires hospitals to monitor for post-IV opioid respiratory depression. Currently, there is no policy in place to enforce this. Approximately 60% of non-surgical patients receive IV opioids during their hospitalization. IV opioids are responsible for 1/3 of all hospital adverse drug events, which is about 600 million cases annually. This carries a burden of $870 per patient affected and increases hospital length of stay by 1.7 days. IV opioids can cause life-threatening respiratory depression. My chart audit revealed that 75% of charts were non-compliant with current CMS guidelines and did not document post-IV opioid respiratory status. 64% were non-compliant with monitoring for post-medication respiratory depression. My team and patient surveys also revealed inadequacies with team communication. Only 60% of patient surveys reported their provider took time to discuss concerns, and only 67% of team members surveyed strongly agreed that maintaining team communication can reduce adverse events. The MOS tool and patient passports can be used to standardize care and also improve communication. The largest benefit that will come from this project is increasing inpatient safety while receiving IV opioids for pain. Providing a guideline for post-IV opioid respiratory monitoring will increase standardization of care and overall patient experience. Respiratory depression can be recognized and intervened upon with appropriate monitoring, reducing the healthcare costs associated with IV opioid adverse drug events. The hospital services also have the potential to bill for respiratory therapies and increase reimbursement. My vision of success would be this project turning into a policy that can be used hospital-wide. My measurement worksheets includes my operational definition. The operational definition of my aim is the average number of how many patients are screened using the MOS tool, plus the average number of how many patients are respiratory monitored. My balancing measure will be increasing in time spent with patient. This will be measured by the previous time spent with patient over the time spent with patient after the project is initiated. Some of my stakeholders include Dr. Story, Dr. Holland, Dr. Harrison, a PA Martin Ricart, and nurse provider liaison Carrie Kennedy. My initial changes include A, team huddles, B, patient passports, C, screening using the MOS, and D, management, which will be interpretation of the MOS score. Listed are my barriers and ways I can try to overcome them. For team huddles, I foresee barriers of lack of huddles when I'm not physically there and staff not coming to meetings. I will increase my presence on the days off and also limit the meetings to 5 minutes. For patient passports, a barrier will be a lack of compliance. I will discuss this with the admission department and have the passports given to patients on admission that encourages patients to ask the provider about them. For screening, lack of compliance will be a barrier. I will try to assist the nurses in filling out some of the tools. And for management, I foresee a barrier of not enough equipment. I will personally stock the units prior to the project start date and email the managers asking for their assistance with keeping the units stocked. There are some of my references.
Great job.
Thanks.
Okay, I will try to go this time. I don't know why I'm having so much trouble using PowerPoint.
All right, Sarah, have at it.
Okay. I am screen sharing, correct? No, I'm not. Okay.
I don't see it.
Okay. Okay, can you guys tell me why I cannot make this full screen for some reason?
Maybe go to slideshow. I don't know. That might help you.
When you're clicking screen share, are you clicking present to everyone?
I thought so. I'm sorry, guys.
That's okay.
I'm gonna miss my 4 points for this. Does somebody else want to go?
I can. But we can wait for you. Are you going to your slideshow?
I think my PowerPoint is like actively trying to shut down.
Oh,
Okay. Can you see this?
yes. There you go.
Okay. Let's do this. Okay. So, hi guys. My name is Sarah Velasco, and my presentation is about improving MIPS measures using effective care and standardized processes in a retail health setting. I will be doing my project at the Little Clinic in Wheat Ridge, Colorado. So my aim statement: improve identified MIPS measures using pre-visit screening and documentation for patients ages 18 and older seen in a retail health clinic to 75% within 90 days. And I'm still working on operationalizing this. Over 59 million Americans are currently receiving Medicare or have an insurance policy using merit-based incentive payment systems for reimbursement. The purpose of MIPS is to focus on 4 metrics, which are to promote cost-effective care and improve care processes, improve health outcomes, and patient engagement. If these processes are not met by clinicians caring for these specific patients, the resulting penalty can be millions of dollars in a lack of reimbursement for services. So, what is the reason for all this effort? Currently, there are no standardized screening processes that exist, leading to missing preventative health information and opportunities for education at the Little Clinic. The Little Clinic has 10 MIPS measures they are currently endorsing, and through chart audits, we found 5 measures had 60% or greater non-compliance, including advanced care planning, immunization rates, and smoking cessation. The team survey results reported 33% of the team members feel like they don't or they can anticipate the needs of each other. 66% feel they can ask for help when they're overwhelmed, and 0% of our team understands their roles and responsibilities in relation to each other. The patient survey also demonstrated patients wanting to take an active role in their healthcare at 95%, but only 50 and 55% respectively felt they had proper information to make healthy choices for themselves and felt they were informed about their health risk factors. So upon completion of this improvement project, the organization will have an appropriate standardized screening tool to implement throughout all TLC clinics. The screening tool will allow for easier documentation for providers, the opportunity for patients to be more engaged in their care, and identify possible patient risk factors. Improvement of the MIPS documentation will have a financial impact in the upcoming years of potentially several $1 million in either incentives or penalties specific for the Little Clinic alone. A shared decision-making aid for vaccinations will streamline the process for identifying a patient's candidacy, assisting them with options to decide on do they want an immunization, and optimally improve vaccination rates and herd immunity within our community. Improving our teamwork and communication will have a lasting impact on the workplace, leading to higher employee and patient satisfaction, improved employee retention, and better workflow. Here you guys can see, this is my measures worksheet broken down, and I have displayed my aim statement, which we've already identified, my processes, or my A through D processes and outcome measures, along with my balancing measure. I look forward to all of your guys' feedback. regarding this. So here are just some of my key stakeholders involved in my project. First and foremost, my patients and the diverse community I serve are my main stakeholder for this project. And you can also see that all of the providers and our patient care techs, and then my immediate team. So my initial changes. Ramp A, team intervention. I'm going to institute daily team huddles with an agenda. Ramp B, patient engagement tool, shared decision-making aid for pneumococcal vaccines. Process 1 tool is going to be a pre-visit screening checklist. And process 2 tool will be a documentation and audit tool, or log, I should say. So what barriers do I predict for my success? I'm concerned about the prioritization of tasks, attendance, and lack of communication in regard to teamwork. For patient engagement, I think the inconsistency of using the tool, increased possible visit times, and the patient not interested in what we're trying to engage them in are going to be barriers. The pre-visit screening checklist that I'm going to use will definitely have a change in our workflow and a possible inconsistency of using the tool. And regarding my documentation and feedback log, this might increase wait times or decrease the amount of total patients that I can see within a day. My last page is my reference that I used. And thank you so much for attending my presentation. Hopefully I can get out of this. There we go.
Good job, Sarah.
Oh, thanks. Am I still screen sharing?
I think so.
My little pop-up. I'm feeling like really challenged.
Don't feel bad. It's usually me.
Oh my gosh. Let's swap places back, Janice. I'm not screen sharing anymore, right?
Correct. You're good now, Ashley.
5 minutes on the mark. Thank you so much.
Okay, I'll go if that's okay.
Sounds good.
My name is Nisha Keeler. My project is improving effective antibiotic stewardship for improved quality patient care in an outpatient clinic. My site is the Little Clinic, which is a retail outpatient clinic located inside Kroger in Columbus, Ohio. The aim of my project is to improve effective antibiotic stewardship based on the Centers for Disease Control and Prevention guidelines by postdating antibiotic prescriptions for improved patient care to 30% in 90 days for all patients that present for upper respiratory infections to an outpatient clinic. In the United States, 2 million people contract illnesses caused by antibiotic-resistant bacteria, of which 23,000 deaths are resulted from these each year. Outpatient settings are responsible for at least 30% of unnecessary antibiotic prescriptions, and 1 out of 5 emergency department visits are due to adverse drug events from antibiotics. Direct patient care due to antibiotic-resistant associated infection costs the U.S. $20 million per year and $35 million for work-related absenteeism and loss of productivity. The Little Clinic currently does not have any formal huddles or meetings, therefore communication lacks between team members. All 8 team members strongly agreed that leaders should create informal opportunities to share information. Almost half of the patients surveyed did not strongly agree that they felt informed about antibiotic risks or benefits. Upon further questioning of patients regarding when antibiotics were necessary, it was evident by some answers that patients do not have adequate education regarding this topic. 63% of patients surveyed strongly agreed, or were neutral about if they expected an antibiotic at the visit. Charts of 60 patients that were diagnosed with URIs, including URIs, sinusitis, bronchitis, and pharyngitis, were audited in October of 2018 at the Little Clinic in various Columbus locations. Results showed that none of the patients that were prescribed antibiotics were written post-dated antibiotic prescriptions. Only 13 of 32 patients that received an antibiotic prescription met the CDC guidelines for needing an antibiotic. Following the effective post-dating of antibiotics and increasing antibiotic stewardship efforts will benefit the team and organization by providing them with a checklist on appropriate antibiotic prescribing. The patients and community will receive improved quality care. The benefits of this project will be improved team communication, patient-centered care, increased patient engagement, fewer antibiotics prescribed, more antibiotics post-dated, less antibiotics filled, less antibiotic resistance, and antibiotic stewardship. Fewer antibiotic prescriptions and less antibiotics filled could mean less cost in healthcare. The company will be left with a HEDL checklist, a shared decision-making aid, an antibiotic screening checklist, and a case management log for continued improvement patient care. My huddle checklist has items that will get scored once reviewed, so that's my process. To measure the outcome, I will survey the team to find out how effective the huddles are based on a Likert scale. The shared decision-making aid will review the patient's symptoms, provide antibiotic education, and then have them list some options for treatment to engage with the provider. To measure the outcome, I will survey the patients to find out how effective the tool is, again, based on a Likert scale. There will be a screening tool that the providers will use to see if the patients need or do not need an antibiotic based on the CDC guidelines. To measure the outcome, I will survey the team to find out how effective the tool is based on a Likert scale. Finally, I'll complete a case management log to see if the providers are following the antibiotic checklist, and the outcome will be measured by this tool. Here are my key stakeholders, which includes my staff. Again, it is me and my tech, my boss and her tech at my location directly. My initial changes include team huddles to engage the team and improve communication, a shared decision-making aid to engage patients, an antibiotic screening checklist for the providers, and a case management log to track the progress. My barriers are that there are only one provider and one MA every day. The other half of the team may not want to come in or participate in huddles. Visit times may take longer. Patients may not be willing to fill out the screening form. Staff may be resistant to changes and be unwilling to use the antibiotic checklist. These are my references. Thank you so much.
Okay, I guess I'm next. Okay, you guys can see my screen, okay?
Now we
No.
can. Now we can.
Okay. Good?
Yes.
All right, let me just look at my... Sorry, I'm having a little bit of technical difficulties here. Okay, I'm ready. You guys ready for me? Okay, my name is Janika Emanuel, and this is my AIM presentation for my project, Improving Performance Metrics in a Community Medicine Clinic, Implementing an Effective Screening and Management Protocol. So my aim is by implementing a standardized screening and management process, we will improve performance metrics in a community medicine clinic for dual-eligible homeless women by 40% within 90 days. Specifically, we will be monitoring the screening of breast and cervical cancer, screening of metabolic syndrome in those prescribed an antipsychotic medication, and administration of influenza and pneumococcal vaccinations. So over 76,000 people in New York City experienced homelessness in 2017. Overall, homeless single adults have higher rates of serious health issues compared to the general population. More than 80% of homeless people have at least one chronic health condition, and more than half have a mental health problem. So this slide compares best practice with what we're currently doing at our clinic based on the chart audit that was performed. The biggest gap was seen for the screening of metabolic syndrome in those prescribing antipsychotic medication. The American Diabetes Association recommends that all those prescribed an antipsychotic have their waist circumference measured at baseline and then annually. And based on the chart audit, 100% of the patients prescribed an antipsychotic did not have a waist circumference documented at any point in time. There was also a gap seen with lipid and A1C levels for those prescribed an antipsychotic. 67% did not have a lipid panel drawn at the recommended intervals, and another 67% did not have an A1C level drawn at the recommended intervals. Also, we do not perform regular huddles at my site, and we do not have any shared decision-making tools that we provide to the patients. So this slide shows the expected benefits of the QI intervention. First and foremost, we will introduce a standardized screening and management process, which would include the use of a pre-visit checklist and a case management log. This new process could help to improve the screening rates of breast and cervical cancer and metabolic syndrome in those prescribed an antipsychotic medication, as well as help to increase the rates of influenza and pneumococcal vaccinations, leading to improved health outcomes. It could also improve the overall clinic workflow and efficiency and help to build relationships between team members. So this slide shows my measures worksheet, which includes the operational definitions for the process and outcome measures for RAMPs A through D, as well as for my aim and balancing measures. We discussed my aim measure. In this slide, you can see my balancing measure, which is staff or team satisfaction will not decrease by more than 15% due to work related to the QI project. My key stakeholders include my clinic staff, aka my team members. I included my sponsor, my mentor, and the medical director of the program underneath the clinic staff, even though they do not practice within this specific clinic, but we do have regular contact in regards to interventions. I also included the shelter staff where the clinic is located, and of course, our patients. These are the initial changes: daily team huddles as my team intervention, patient passport as my patient engagement tool, pre-visit checklist as my process 1 tool, and my case management log as process 2 tool. Some barriers include time constraints and staff resistance to daily huddles. For the patient engagement, lack of patient interest, lack of available patient passports. For my process 1 tool, could be poor compliance with the use of the checklist depending on how busy the clinic is. And for my process 2 tool, staff may just forget to enter patients into the log. And these are my references. Thank you.
All right, ready to boogie on the last one?
Let's do it.
All right, here we go. Can you guys see that okay?
Mm-hmm.
Okay, awesome. All right. So my name is Ashley Kwasinski, and I work at Aurora Healthcare in Milwaukee, and I'm doing my project on the implementation of an inpatient screening checklist to increase effective utilization of Clostridium difficile testing. The toolkits I'm using include SMART goals, the Clostridium difficile screening checklist, and the Bristol stool chart. My aim is to increase effective screening of inpatients for Clostridium difficile or C. diff to 90% in 90 days through the use of a Bristol stool chart and a data checklist. The problem within my facility is that there's no guideline utilized within our inpatient setting for why we are testing C. diff. Every month, 20% get ordered inappropriately. Additionally, there's poor outcomes, which has led to increased cost to our system and patients, a waste of labor as well as resources, and unnecessary antibiotic use, which can increase resistance among patients. There's also been hospital metrics reported to the community that have been poor related to positive C. diffs and testing. Inappropriate C. diff testing also leads to increased false positives, unnecessary therapy. There's also a study out by Miller in 2017 that talked about 20 to 44% that were tested for C. diff were on a laxative. So the rationale for my project is that there is a need for an improved process on effective C. diff testing. Based on surveys that I did for the nurses on the floors, there was a lack in communication among the nurses and the providers. Patients that I surveyed also reported not feeling to responded to as quickly if they were in isolation. A big problem was there's not a consistent tool utilized for assessing a patient's stool. So there's often different reports and different descriptions given. Our facility also fails to track the subjective and objective patient data that goes along with getting a C. diff test ordered. Outcomes for patients include decreased cost and length of stay and increased satisfaction. Less antibiotic use and less resistance is also a positive for patients. Caregivers will be happier in their jobs and have less animosity. For my organization, it is value-driven, including less waste of resources and funds. I'm most excited about hopefully implementing a standardization of a stool reporting tool as well as improved metrics for my facility. Short-term goals include a data-proven effective measures from the product. Long-term, I'm looking at EMR implementation and implementation of a diagnostic stewardship committee within my facility and hopefully organization. My measures, my aim includes to increase effective screening of inpatients for C. diff to 90% in 90 days through the use of the Bristol stool chart and a data checklist. My balancing measure for this is the staff perceive increased workload with the project. I will get that from a team engagement survey question. Here are my measures. My ramp A will be a weekly QI meeting where I will give surveys out and I will find out the mean effectiveness of that survey. My patient engagement tool will be the Bristol stool chart. I'd like to see how many times it's utilized based on the patients on the unit. My data checklist will be used to determine the number of screening checklists that were completed for patients being tested for C. diff. And my case management log will be averaged out to find out if it's been utilized correctly with the right care bundle. Stakeholders include patients, all the participating units, which are 5 at my facility, the hospital and the organization, my faculty and team here at Frontier, as well as infection prevention, pharmacy, antimicrobial stewardship, IT, EMR, and lab. Festive things include the weekly QI meeting using SMART goals, Bristol stool chart, the C. diff education handout that my facility provides, and a patient learning checklist. The C. diff screening order checklist will be used by providers, and a case management log will be used for screening and data tracking. Barriers include teams unable to attend meetings or loss of interest, not utilizing the stool chart or reporting stool from the chart. Providers also might not complete the checklist or not have access to it. And I'm very concerned that there may be too little data to enter that I might make a data entry here. And those are my references. Thank you.
It was so fun to see all of our stuff actually come together, or at least come together in a PowerPoint presentation.
Yeah.
All right, guys, we've got some discussion questions to go over. Does anybody have anything that they want to start with any of the ones that we 1 through 5?
I liked Danica's background on her problem. I like hearing about there seemed to be a multiple amount of different things that needed to be screened for at the place where you're doing this at. So I thought that was really interesting to hear.
Yeah, thanks.
Janice, I was impressed by the $1.1 trillion that it costs for the readmissions in your PowerPoint.
Yes, that is a frightening number, but the number of people we see just in our local organization, it seems to increase, and the people are getting so much younger. You know, we get the postpartum cardiomyopathies, the young women, and it's so sad to see these people having to get ICDs, you know, in their 20s. But I have several postpartum patients, and you know, the cost of those devices is somewhere around 80,000. Cost is so great because when they don't recover, and it's a 50% possibility that people will recover and get an ejection fraction that is improved. But if it's ischemic heart disease that causes the problem, those are the ones that seem to do the worst. You know, people who've had a heart attack or have a blockage, they do worse.
Janice, I feel like you always have a lot of compelling evidence on your PowerPoints.
Thank you.
You're able to speak it well and present it well and really engage the audience and shock them with the wow factors of those numbers. You're welcome.
Yeah.
I'm really excited to see how your project unfolds, just because I feel like it has such a substantial impact on your community.
Well, thank you. I hope I'm still standing to see it through.
Well, it sounds like we're going to have a fair amount of discussions over the next 3 months for all of us to check in.
Yeah.
Amanda, I like that you were able to also have an actual number for how much, you know, your complications could possibly cost your patients. I thought, I don't know, the actual data that you guys are able to produce regarding, you know, specifically same thing, you know, with Janice, how she had a specific number. It's just the wow factor of it.
Yeah.
Amanda, you're from North Carolina too, right?
Yes, ma'am.
We're in the Bible Belt of illness.
Yes.
North Carolina, lots of illness.
I was surprised by Amanda, your the 60% that of non-surgical patients receive IV opioids. That was kind of like, whoa.
Yes, it blows me away.
Yeah.
You say why?
Right, exactly. Why are they doing that to them? So I was surprised by that.
One thing I found, I guess that really shocked me when I was doing more research with this, we use Epic as our like medical record at the hospital, and on the admission part, there's one general admission that I hardly ever use because I usually specify on to why the patient's there. But under one general admission, you know, that you can use just to admit somebody to the hospital, some of the standing orders include Loratab for pain, morphine IV for pain, and then it escalates to Dilaudid IV for pain, and then Ambien for sleep and Xanax for anxiety. And I'm like, why is this defaulting already ordering this for every patient, even if you're coming to the hospital because you have, oh, I don't know, an eye infection or something? If you're being admitted, it just really shocked me how lax that.
It was
you know, we're supposed to be strict with all these controlled substance, but this Epic that I'm sure thousands of hospitals use, that millions of patients come in contact with, you know, you're admitted to the hospital, that's already going to be on your admission orders unless somebody goes through and unclicks those buttons.
So when I was a floor nurse, I was postpartum, and some of these intact vaginal deliveries were being given Percocet.
Yeah.
Why? Like, why? And then I had surgical patients, you know, C-sections that, do you need a Motrin? No. You know, so they weren't even taking a Motrin for pain. So I'm just surprised by these numbers sometimes.
There is a large kind of disparity about these narcotics and controlled substance, about who gets them, who doesn't, and how easy or controlled they are, or hard to give.
Yeah. Janice, I wanted to let you know that I really found your PowerPoint to be, you know, graphically, I think it was done well. The colors were nice, and it wasn't just all words, and there was nice graphics and the way you presented your information. I thought it was really well done.
Well, thank you. Thanks.
Yeah, I thought Ashley's was too. The way you presented it, when you had little bits of information with a little icon over each one, it was easy to follow.
Right.
And even if it had a check sign, it was something we were checking, or if there was a little dollar sign, it was something about money. I thought that was nice.
I agree. It was visually appealing. It was concise. It was just really easy to follow.
PowerPoint's come a long way.
Sarah, yours had really nice color in it, so that made it appealing in that aspect. Some of the so I had a hard time seeing some of the words, but the colors were it kept you attracted to the to the actual PowerPoint.
Well, I'm sure you guys deal with this, that when you're going through your design and you're like, oh my gosh, I feel like I just did that one last week. And they all look the same.
Yeah.
I like seeing all of our barriers too. It's so nice to know that we're all going to end up, or, we're all concerned about the same barriers of like how to engage your team. Like, obviously this, implementing something new, there's always a workflow concern, and you always have that one like crappy person who says that they want to help you, but they don't actually want to help you.
It's true.
Well, I don't know what you guys do at your facilities, but at my facility, they just changed how nurses, we call it staging or advance, and that it's basically like how they like kind of get raises basically, and they have to be like involved in things now. It's not so much now how long you've like worked there, but more like what you're involved in. So I kind of sold some of them being involved on my team that you could put this on your resume and use it too for kind of doing your staging for 2019 and getting basically something to help you get your raise next year. So if you guys
that's a good idea.
Oh, I thought that was a cool thing.
Money is always a good incentive.
Yeah.
Right.
The hospital I used to work at, we called it our pad, which I thought was so weird. Like, oh yeah, like we got to just work on our pad, and you're like, what? But it no
pad of money.
Yeah, it was like, okay, yeah, like, but you had to start on it 3 months ahead of time. Like they sent you it ahead of time, and it was 4 pages long, and it was like a exceed, meet, whatever, like a 5% like category thing, but you had to justify with examples and documentation under each section why you deserve it. And so like you had to sit on committees and be involved in QI stuff. And after going through this entire project, I'm like, if I had only stayed at an RN job, I was involved in a 3-year hand hygiene QI project that went hospital wide that I championed, like multidisciplinary, like among the physician teams, like implementing apps and like new signage for the hospital. I'm like, oh my gosh, this is way better than my little MIPS checklist I'm doing.
That seems rather frustrating though, to have to do that to get
a raise. Yeah, it
seems like, especially, and it's probably horrible for me to say this, but it seems like an organization's way of not giving raises for the people who aren't going to do that, fill out this form. There's going to be several nurses who have been a nurse for 20, 25 years, and they're not going to fill out that form. They're not going to write that paragraph, but they're just as good.
Otherwise, you're let go. Like it is your annual review, and you sit down for like an hour with your supervisor, and you review it, and then it's submitted. But like it's part of a clinical letter. So like you were an RN2, and then as you got higher up within your pay grade for the RN2, even if you exceeded, you cap out at like a pay, and you only get like a 1% raise. So then you're like incentivized to get your CLIN3, which I got suckered into doing, and submitted like an 85-page packet on my greatness, which is essentially what it is. Like all these different categories, like spiral bound, submitted to a committee, a formal committee that's then reviewed from all over the hospital. And they gave you like a big raise off the bat to get it, but then you're obligated to more stuff to maintain your clinical, your new clinical status.
So complicated. What happened to just being a nurse?
No,
you got
no such thing
here, and that was that.
Okay, guys, back to these questions. Sorry. Anybody else have anything to add to these?
Oh, I did. What about I'm sorry to interrupt you. About the health disparities, I wanted to mention, Janika, with your presentation, I really like how you incorporated those pictures. I knew it had to do with the homelessness, but when you incorporated the pictures in there, it really kind of makes you step back and look at it. For me, it helped me kind of understand it more and visualize it more.
Like connect it a little bit better.
Yeah, I agree, Janika. I like your the disparities that you presented. You had like women, elderly, and children. And then Sarah, you had things about people like needing vaccinations, which is a big thing right now that people are kind of hot and bothered about. And then you talked about like the lack of funds, which is also a thing, disparity among people right now, and the lack of information given out. That seems to be a big topic among patients when they report and they're like surveys. They didn't understand what people were talking about or what they were diagnosed with.
Yeah, it's like mind-boggling to me. You know, one of the things that I found when I was doing my initial surveys was how many patients came in to see me expecting medications to be given, say antibiotics for sinusitis or something. And you're like, what medications are you taking? And they're like, ooh, I think I'm taking something for high blood pressure. And I'm like, ooh, let me read your mind on what it might be. You know, like how many people came in with like, you know, multiple comorbidities where I would have to call their pharmacy to find out what medications they were taking, what doses they were taking. Like patients didn't even know why they were taking some of their meds. And, you know, like I'm expected to see roughly 4 patients an hour at my clinic. And like, you don't have time to be on the phone with the pharmacy or like, I don't want to say you don't have time to not talk to them about this, but like somebody has failed them along the way that they have been given medications for hypertension, but don't know that they even have hypertension or that they could just shed 10 pounds and, you know, like, but I work in a retail health clinic. Like there's only so much you can do. I'm sure you all feel that way.
Shanika, I was going to ask at your clinic, do you all have resources sometimes or other resources that you're affiliated with to help these homeless people actually get homes? I know you're seeing them to try to keep them healthier.
Yeah, so we work together with the shelter. So we're located within the shelter, and we serve the patients within that specific shelter. And we do psychiatric evaluations, physicals, TB screening, for them to submit for their housing packet so they can try and get supportive housing based on so if you have a certain medical condition, if you have a serious mental illness, you can qualify for services such as supportive housing, visiting nurse services, things like that. So the whole reason why we're there is mainly to do these type of evaluations so that they can submit for housing, but they also see us for follow-up care. They've switched to us as their primary care providers. We have outpatient clinics as well. So when they do move out, they can still continue receiving services from us.
That's good.
Yeah. And it's sad because they really need the services. And like Sarah was saying, you know, a lot of my patients, they've been failed along the way. They don't know what half their diagnoses mean. Don't ask a patient what it means to be bipolar or what blood pressure medications they're taking. Nobody has sat down with them to kind of discuss these things with them. So a lot of it falls on us, which is why I'm really excited to do this project, because a lot of them are willing to learn more about their illnesses and how to better take care of themselves. They just have never been given that opportunity to, you know, work together with the provider to do that. So.
Okay. Does anybody else have anything they want to talk about within the discussion questions?
I'll be right back. I have to get my charger. I'm at 2%.
I didn't have any more questions on the discussion, but I was just wondering how we record our reflection. Are we just doing that like via like a video, say on our phone, and then submitting that, or are we going through the YouTube thing here, or what? How does that work?
I think whenever you're submitting it. Oh, nope, I'm wrong. Never mind.
I think you can do any of that. I think you can just do a voice recording. I think you can do a video.
Okay.
Yeah. And
Got
so
it.
as long, yeah, you can do a written one if you want. So it's really up to you how you choose to do it.
Okay.
Yeah, when you go to upload it, instead of file upload, you just go over to the right and hit text entry, and then there's a little spot where you can insert media, and I think it'll record you.
Okay. Got it. Okay.
And we as long as we have those by Sunday, is that correct?
I think so.
Yeah.
We don't have to do that tonight, is I guess what I'm asking.
No, you have to, yeah, you have to do like, the reflection is based on other things anyway. So it has to, this had to be done in order to do the reflection. So I think you have till Sunday to do it. So, yeah.
Okay. Sunday's the big day for a lot of things.
It's either going to be 6 more months of school or starting our vacation early.
Where are we going on vacation?
Caribbean, anywhere in the Caribbean where it's warm.
After 6 months, ladies. After.
190 days.
There you go. All right. I think that concludes our recording.
Alrighty, I'm going to go ahead and stop our broadcasting.